Hi class, welcome to Unit 6, Part 2, where we're going to talk about musculoskeletal function in greater detail. So let's first talk with the functions of the musculoskeletal system. It protects the vital organs, has a framework to support our body structures and offer us mobility and movement. It helps facilitate the return of the blood to the heart and acts as a reservoir for nutrients, minerals, and red blood cells. There's about 206 bones in the body, and then we've got our joints and our muscles. The musculoskeletal system is the second largest body system. Bones account for 99% of the calcium in the body and about 90% of the phosphorus. Joints are a space in which two or more bones come together. There are three types of joints in the body, depending on how movable they are. There are some age-related changes that occur in the musculoskeletal system. As the patient's age, you will have a decrease in bone density, and that can be related to diseases like osteoporosis or osteopenia. And that decrease in bone density can cause changes to gait and predispose older patients to fractures. There can be atrophy of muscle tissue, so activity and exercise may slow down. We can see degeneration of cartilage, which means a loss of elasticity, and that can cause osteoarthritis. And the fourth thing is reduced range of motion of joints, and again, that can cause gait changes. So ways that our body tries to maintain our bones are listed here. Our bones are constantly changing and reforming, redeveloping. It's dependent on body stress and weight-bearing activity, the amount of calcium and vitamin D, the blood supply, the parathyroid hormone and calcitonin. All of those things help regulate bones and keep them constantly remodeling. If there is a bone that needs to be repaired due to like a fracture, there's stages that occur to change over and heal that bone. Again, I'm not going to really test you on these processes. It's more of just a review for you. And then, of course, we can't have the skeletal system without the muscles. Muscles are attached to bones and other structures through our tendons. And they're all encased in a fibrous tissue called fascia. And if you listen to the other Unit 6 recording, I talk about the fascia and how it is forming compartments, and how if there's swelling within a compartment, that is compartment syndrome and is an emergency. Our muscles do contract to shorten and do forward motion. Let's see, our assessment of the musculoskeletal system, pretty straightforward. Can they do their activities of daily living? Can they do their instrumental activities of daily living? So these are assessments that need to be made because they help evaluate people with diseases to see how severe their disease is and how and what way does it limit the person's ability to care for themselves. We'll also look at general health, family history, what's their occupation, what are their learning needs, what are any socioeconomic factors, and do they take any medications that may have long-term consequences to the musculoskeletal system. For example, long-term use of glucocorticoid steroids can cause a loss of bone density over time. Then we do our physical assessment. So that is, we're going to be palpating for masses, for tenderness, for crepitus, for drainage from ears, like hearing loss. Let's see, spine, neck, hands, hips, feet, and ankles. We want to inspect and palpate the joints, looking for flexibility. Can they fully move each joint? Do they have full range of motion? Do they have any pain? If there is pain, you want to ask all the pain questions. We want to do our neurovascular assessment, also sometimes called a circulation check. So palpation of the pulses in the extremities, especially distal to any injury, sensation, movement, color, temperature, pain, always comparing one side to another. And then there are diagnostic tests, which I'm sorry, let me just correct this so you can see them on the screen. There we go. So let's talk about these tests. So you've got your standard x-rays, your CT, your MRIs. Arthrography, arthroscopy, they're looking at the inside of joints. They can insert a fiber optic into the end and look visually with a light and a magnifying lens to see what's going on in there. It can help to evaluate and diagnose joint conditions and unexplained pain. It can help detect diseases with ligaments, tendons, and cartilage. We can do it where we inject contrast material into the bloodstream. We can inject contrast material right into the joint and then run them through a scanner to see where that contrast travels to and see if there's any sort of problems versus a normal pathway versus, damaged pathways. Let's see. Bone scans. That's when we use radio opaque material and scan for any sort of suspicious areas throughout the whole musculoskeletal system. Let's see. Reasons for doing the diagnosis or diagnostic tests are listed on this slide. What nursing considerations do you have for each of these tests? So with an MRI, we usually assume that they're going to get some contrast. So we have to assess for allergies like iodine, shellfish. We would definitely want to look at their renal function. We would want to assess to see if they're on medications like metformin, which if we give metformin with IV contrast, it can cause renal failure. They're going to hear knocking noises and be in a small space. With arthrography, they may feel some discomfort and tingling. Their joints might be a little bit noisy for the first 1 to 2 days afterwards. Bone scan, again, we're assessing for allergies. We're encouraging fluid intake. Arthroscopy, their joint is going to be compression wrapped afterwards to control swelling, and you need to monitor their neurological status and then give them the signs and symptoms of complications, so risk for infection. Let's see, we can have arthrocentesis, so that's when we're going to go in and remove a little bit of fluid. We can have electromyography. That's a diagnostic procedure to assess the health of the muscles and nerves. It uses little electrodes to transmit and detect electrical signals. They can use a needle EMG, and that when they put a needle electrode right into a muscle, that can detect some nerve dysfunction or nerve to muscle transmission dysfunction. And if your patient is taking a muscle relaxers, they should discontinue that 2 days before the test. Biopsy is pretty straightforward. Laboratory values, calcium. Remember, our calcium can be measured two ways. Serum calcium is the most common, so that's the total amount of calcium in the blood, and that can be affected by low albumin levels. We have phosphorus, which of course has an inverse relationship with calcium. Our alkaline phosphate, our CK, which is used to detect inflammation in the muscles, CKMB, which can be used as a follow-up test to an elevated CK to try to determine what type of muscle inflammation is going on. CKMB is definitely a little bit of a second step, a little more detailed lab value. Okay, so let's switch and talk about musculoskeletal care modalities. And casting. All right, so what is a cast? It's a rigid external immobilizing device. It immobilizes a reduced fracture. It can correct a deformity. It helps apply uniform pressure to soft tissues, and it can stabilize and support weakened joints. You could either have a plaster of Paris or a fiberglass cast. This is just a picture of the two different, like a long arm, short leg casts, and then remembering that there's pressure points inside those casts. So we need to make sure we're doing good neurovascular assessments. Distal. So if it's an arm cast, the fingers. If it's a leg cast, the toes. Then we've got our splints and braces. These are for conditions that don't require rigid immobilization, or if we expect a fair amount of swelling. And they can be a custom fit to the individual's body part to protect against injury. When we are taking care of a patient with a brace, a splint, or a cast, before applying, we're going to do a health assessment, emotional status, and then a full assessment of the presenting signs and symptoms and condition of the area. Throughout the pre, during, and post, we're going to be monitoring the neurovascular status and assessing for potential complications. We're going to treat any lacerations or abrasions before applying the cast, brace, or splint, and provide patient education so they're prepared and know what to expect. Neurovascular changes, the 6 Ps: pain, pulcothermia, pallor, pulselessness, paresthesia. 1, 2, 3, 4, 5, 6. Sorry, I was just counting to make sure there was 6 of them there. And then pain, a good pain assessment, we can treat it with elevation, ice packs, and analgesics. Then we've got complications, compartment syndrome. It is a serious complication. It occurs from increased pressure in a confined space that compromises blood flow. Ischemia and irreversible damage can happen within hours. So that is why we have to do that clinical assessment of the 6 Ps. And pain that is unrelieved by analgesia is a classic symptom of compartment syndrome. So we have to notify the healthcare provider, and we may need to remove whatever type of casting device is on and do emergency surgery to relieve the pressure in that fascia. Then we've got, sorry, I'm just moving this down, pressure ulcers. So if we ignore painful reports of a specific area that is especially painful or tight, it can develop a pressure ulcer. And then what we can do is we can cut out part of the cast to look at it and assess, and then either recast it or just apply a dressing over it. Disuse syndrome is when we don't use our range of motion exercises to keep up the regular function. And it's just due to disuse, not using it, and the muscle atrophies and we lose strength. Let's see. So then we get to the education needs. What's the impact of this cast, brace, or splint on their activities of daily living? Exercise, rest, what meds do they have to take? How do they control swelling or pain? What can they do if they experience some minor skin irritation? We want to tell them not to stick foreign objects in their cast because they may not be able to get it back out, and then they've created something that can cause a pressure ulcer. The signs and symptoms to report: persistent pain, swelling, changes in sensation, movement, skin color, temperature, signs and symptoms of infection or pressure area. We have to educate them to their follow-up care, the cast removal, and there's also a chart 40-2 you can take a look at. We can also use external fixation devices. Those are used to manage open fractures with soft tissue damage. They can provide support. Patients need assurance because they look kind of scary. And there's going to be a picture on the next slide. Discomfort's usually minimal. It does have a risk for infection. That's probably the biggest risk because the pins require specific care. So let's take a look at this. This is an external fixation. So each one of these pins that's going in from the outside to the bone, each one of those have to have individual pin care. So we treat each pin as its own wound. So you use a separate cleaning cotton swab applicator for each one of those insertion sites. And we have to be diligent in assessing for signs and symptoms of infection. There are some advantages to external fixations. They have minimal blood loss, they allow for early ambulation, and they promote healing. The big risk, though, is that risk for infection. So if a site around the pin has swelling, redness, crusting, I want you to think, ooh, I need to get a wound culture, because the pin extends to the bone, which gives bacteria a free ride to infect our inner tissues, which is very bad. Okay, so then let's talk traction. Traction is just what we call when we apply pulling force to a part of the body to realign and immobilize fractures. It also can help reduce muscle spasms as well. It's typically a short-term intervention until other modalities are possible. And the next slide is a picture. Let me just move the text down so you can see that. So all traction has to be applied in two directions. The lines of pull are called vectors of force, and it's those lines of force that kind of keeps everything in alignment. So what are the principles for traction? So whenever traction's applied, a counter force must be applied. Frequently, that's the patient's own body weight. Traction has to be continuous. And the weights are never removed unless intermittent traction is prescribed by the provider. Any other factors that reduces pull must be eliminated. All ropes must be unobstructed. Weights must hang freely. Knots or the foot plate must not touch the foot of the bed. So there are different types of traction. Bucks, cervical, pelvic for skin, and then there's skeletal. This slide, critically important nursing consideration is to make sure the traction is intact. If the weights are on the floor, we have a big problem and we need to notify the MD immediately, because the whole purpose is help to align the bone. So if things aren't as they're supposed to be, we are no longer aligning the bone properly. Okay. This is an example of bucks. This is skeletal. Basically, both ends of the fracture have to be properly aligned. The weights have to apply counter traction. We encourage the patient to be mobile in bed by having the hand grip so that they can reposition themselves, so we maintain that mobility of the upper extremity while keeping the lower extremity in alignment. If your patient is in skin traction, we've got to make sure everything is lined up the way it's supposed to be. We've got to monitor for complications like skin breakdown, nerve damage, circulatory impairment. So those 6 P's, preventing DVTs, preventing skin breakdown, preventing infection, all of these are critically important. We also want to evaluate the traction apparatus, patient position, keeping in mind that we have to keep our body in proper alignment so everything heals and functions as well as possible. Pain must be reported promptly. We use the hand grip or the trapeze to help the patient reposition, and being able to reposition themselves will help relieve pressure points. And we do have to assess a patient that's bedbound due to traction for pressure points at least once every 8-hour shift. We're going to use special mattresses, pressure reduction devices, and then we're going to perform foot and leg exercises every hour so that we avoid disuse syndrome. We're going to use TED hose, SCDs, anticoagulants to avoid DVTs. We're going to provide meticulous pin care, exercises. We're going to assess anxiety, assist with self-care, monitor and manage any complications like atelectasis, so cough and deep breathe, constipation, use of stool softeners, anorexia, what sounds good to the patient to eat, urinary stasis, are we encouraging them to raise the head of the bed, void when they feel the need, infection, DVT, pressure ulcers, that sort of thing. So then we get to, let's say they've had a joint replaced. So this is usually reserved for severe joint pain and disability. The most frequently replaced joints are hip, knee, and finger. Shoulder, wrist, and ankle can also be replaced. When we have a patient with hip surgery, we want to prevent dislocation of the hip prosthesis. So that means we have to limit the flexing of the hip. They can't bend down more than 90s. And we have to keep the hip in abduction when turning, adduction when transferring, so we don't pop that out of its location. Usually they're going to be post-op day 1 up walking, and we're going to assess any drains that are left in place for bleeding and fluid accumulation, and that's usually discontinued as quickly as possible post-surgically. We also want to prevent infection, so good hand hygiene, and these people are at risk for infection for up to 24 months. So if a patient has had a recent hip surgery and they come in with non-specific fever, malaise, we've got to think, could it be the hip that's the problem? We want to prevent DVTs, whether it's exercises, TED hose, SCDs, plus Lovenox, that sort of thing. This is a picture of an abduction pillow that we can use after a total hip replacement to ensure that it stays in proper position. People that have had knee replacement, they're going to have a compression bandage on their knee. We're going to have to assess neurovascular status every 2 to 4 hours, more frequently if you notice anything that's not quite right. The complications we're going to monitor for are venous thromboembolism, infection, and bleeding. They may have a drain in place that just facilitates the healing process. They may be on some antibiotics prophylactically to minimize the risk of infection. They may have an order to auto-transfuse blood that has been removed from their own body. Let's see. Continuous passive motion. I want you just to know what it is, but it's not commonly prescribed anymore. It's a CPM. It's a device that kind of just continually moves the leg, and it seems like it's gone in and out of use, and I'm not sure what the research says is best practice, but it seems like it goes away and comes back every so many years. We're also going to do physical therapy. We're going to do acute rehab, and the total recovery is about 6 weeks at a minimum. Let's see. So caring for these patients post-operatively, pain, vitals, especially respirations and breath sounds, level of consciousness, neurovascular status, and tissue perfusion, especially distal to the wound, signs and symptoms of bleeding, looking at that incision or the wound, mobility and understanding mobility restrictions, bowel sounds, bowel elimination, urinary output, signs and symptoms of complication, DVT or infection. And here's that neurovascular assessment back to haunt us again. That's why it's so important to know what goes into a neurovascular assessment and that we're doing a full assessment. Then we've got, what are the nursing diagnoses? These are the pertinent nursing diagnoses. What are all the complications that we want to have in the front of our mind? Hypovolemic shock, atelectasis leading to pneumonia, urinary retention, etc., etc. Then we've got major goals before and after surgery. We've got medications. Usually these people are going to be on a PCA, so be sure to read up about what the care of a patient with a PCA involves. Repositioning, distraction, hot and cold, elevation, immobilization, all of these are very useful and should be utilized for pain management. And then the last slide here is, so ankle calf exercises to prevent DVT, measures for adequate hydration and nutrition. We should be doing frequent turning and repositioning. We should be following any PT or OT orders, and then encourage the patient to set realistic goals and do as much self-care as they can within the limits of their PT orders or therapeutic regimen, because we want to optimize their independence and progress their healing process safely so that they get back to 100% in a safe and efficient way. So a lot of things to consider about, so take your time. I have just hit the high points on each of these slides. Be sure to go back and read through a lot of these key points and make sure that they're in the forefront of your mind. And as always, thank you for listening, and please let me know if you have any questions.